Hello, everyone. Welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm excited to be back. My name is Ismail Abdullah and will be your host for today's episode. And I'm joined by my dear friend Kenan to discuss acute leukemias, myelodysplasias, and the scary oncogenic emergencies that make every doctor sweat just a little bit. Kenan, welcome to today's discussion.
Thank you for having me. I'm very happy to be here. These are essential topics in hematology and oncology, so let's get started.
All right. Kenan, go ahead and set the stage for us. When we hear the word leukemia or myelodysplasia, what exactly is breaking down in the bone marrow?
طيب, Bismillah. Let's look at the bone marrow like it's a factory. Its job is to produce the different cells, which are red blood cells, white blood cells, and platelets. Now, in leukemias, there's a glitch in the system where the factory assembly line gets blocked, leading it to getting clogged with immature, useless cells called blasts that multiply out of control. They crowd the factory floor so no healthy products can get out, leading to bone marrow failure. While in myelodysplasias or MDS, the factory is actually overworking. It's very hyperactive, but the quality control is non existent. That it produces defective, misshapen blood cells that don't work properly. Therefore, the bone marrow is not able to keep up with the body's demands, not because there are no cells, but because there's a lot of poor quality ones. We call this ineffective hematopoiesis.
Love that analogy. So, leukemia is a block production line, and MDS is a critical quality control failure. What really causes the initial jam in leukemia?
We often explain it using a two-hit model. Imagine a cell needs two separate malfunctions to become leukemic. The first hit is like jamming the accelerator, a gain of function mutation in genes like FLT3 or BCR-ABL. That makes a cell multiply non-stop. The second hit is like cutting the brakes and removing the steering wheel. A loss of function mutation in genes needed for differentiation like PML, RAR, alpha. The cell can't mature properly, so it's speeding out of control and can't mature.
That really clarifies the pathophysiology. Now, podbiters, let's jump into our first case. So, picture this. A 6-year-old boy is brought in with the history of fever, extreme tiredness, and no appetite starting a week ago. He's had a nosebleed, and his mom noticed new bruises on his arms and legs. The doctor finds swollen lymph nodes everywhere and an enlarged liver and spleen. His blood count was alarming, a white blood cell count of 42,000 with low hemoglobin and platelets. And critically speaking, 34% of those white cells are blasts. When you hear such a scenario, what is the top differential that hits your brain?
Tamam. That is the textbook classical presentation for acute lymphoblastic leukemia, or ALL for short. All the signs point to it.
I ask you kindly to walk us through why it screams ALL to you.
Well, firstly, the epidemiology fits perfectly. ALL is the most common cancer in children, making about 80% of childhood leukemias. It peaks between ages 2 and 5 and has a second smaller peak later in life around the age of 48, and is more common in males. In this case, the symptoms come from two places. First, the bone marrow failure. As we said earlier, the blasts are crowding out the good cells, so there are no good RBCs, WBCs, or platelets. The bad WBCs are causing the infections via neutropenia. The bad and reduced RBCs are causing his anemia like symptoms such as his fatigue, and the thrombocytopenia are causing the bleeding and bruising. Secondly, the physical findings is due to tissue infiltration. The blasts are invading the organs, causing the swollen lymph nodes, enlarged liver and spleen. Other issues they can also cause are bone pain, testicular involvement, and even CNS involvement, leading to seizures.
Right, and what about the classic constitutional symptoms and the risk of leukostasis?
بالضبط. Patients can have fevers, weight loss, and fatigue. And with a very high WBC, you can get leukostasis, where blasts sludge in small vessels, potentially causing stroke-like symptoms or lung problems. Another possible complication is very dangerous and is known as DIC, or disseminated intravascular coagulation.
And what about the causes?
Mostly, we don't find a specific cause, and we call that idiopathic. But we know risk factors like Down syndrome, other genetic factor conditions like Li-Fraumeni and Bloom syndrome, or even previous exposure to radiation, chemotherapy like alkylating agents, or chemicals like benzene. Infections like EBV are also on the list.
Perfect. So now, How do we confirm that this is ALL and not one of the other leukemias?
The gold standard is always going to be a bone marrow biopsy. We need to see that over 20% of the cells are blasts. Under the microscope, these lymphoblasts look very immature, and they appear as high nuclear to cytoplasmic ratio, a round nucleus with immature chromatin, and prominent nucleoli. We then use cytochemistry, like a positive TDT stain, and flow cytometry to see if it's a B cell or T cell ALL. B cell is more common, with markers like CD10, 19, and 20. T cell ALL has markers CD3, CD5, and CD7. Moreover, genetic tests are crucial for prognosis. I'd like to add that if you want to remember it, CD10, 19, and 20 are bigger numbers, hence B cell, while T are the opposite, where they're smaller, so 3, 5, and 7.
Speaking of prognosis and treatment, it's not a one-size-fits-all approach anymore, isn't it? Or is it?
Not at all. We stratify patients. Favorable features include B cell type, no CNS involvement, and no genetic modifications like translocation. Unfavorable features include T cell type, CNS disease, and high risk genetics like the famous Philadelphia chromosome, which is a translocation of 922. Treatment starts with the intense combination chemotherapy. So we now have incredible tools like imatinib for that Philadelphia chromosome, blinatumomab, a monoclonal antibody, and even CAR T cell therapy, where we engineer a patient's own immune cells to hunt down the leukemia.
It's interesting how personalized it's become. All right, Kenan, let's pause for a quick question for our listeners.
A 7-year-old patient is suspected of having acute lymphoblastic leukemia, ALL. Which of the following findings is essential to confirm diagnosis of ALL? A. Presence of our rods on peripheral blood smear. B. Elevated serum lactate dehydrogenase LDH level. C. Bone marrow biopsy showing more than 20% lymphoblasts. D. Identification of BCR ABL translocation via genetic testing.
And the correct answer is C. Bone marrow biopsy showing more than 20% lymphoblasts, which is a cutoff point for leukemia. Hit me with another question.
Okay, Ismail. During the diagnostic workup of a patient with suspected acute lymphoblastic leukemia, flow cytometry is performed. The results show a population of cells that are positive for CD10, 19, and 20. What is the most likely subtype of ALL and what's the common clinical presentation associated with this subtype? A. T cell ALL commonly presents with a mediastinal mass. B. B cell ALL commonly presents with testicular or CNS involvement. C. B cell ALL commonly presents with splenomegaly and gum hyperplasia. D. T cell ALL, which commonly presents with disseminated intravascular coagulation, DIC.
I'm confident that the PodBiters listening to us right now are going to answer B. B cell ALL commonly presents with testicular or CNS involvement. Now, let's shift gears to a new patient. A 55-year-old adult comes into the clinic feeling profoundly fatigued and dizzy from anemia. They've also noticed their gums bleeding and seem to be swollen. Their blood work shows blasts, and the bone marrow biopsy confirms leukemia. But this time, the report mentions some of the blasts have our roads. What does this instantly tell you?
Aywa, the hour rod. It immediately points us towards acute myeloid leukemia, or AML. This is the most common acute leukemia in adults.
All right, but what exactly is an hour rod?
It's a needle-like structure inside the blast, formed by abnormal crystallization of granules that is MPO positive. It's pathognomic for AML. Bimana, if you see it, you're dealing with AML.
So, while the symptoms of bone marrow failure like infection, anemia, bleeding are similar to ALL, the gum swelling and those hour rods are key clues for AML. What puts someone at risk for having acute myeloid leukemia?
Good question. Similar to ALL, there are genetic syndromes like Bloom syndrome, Fanconi anemia, and Down syndrome. In addition to that, exposures to things like tobacco, pesticides, benzene, radiation, or even certain chemotherapies like topoisomerase II inhibitors. A particularly important risk factor is a prior history of myelodysplastic syndromes, MDS for short, like chronic myeloid leukemia, or CML for short, which we will talk about soon.
I have a question for you. Do we also do flow cytometry for AML?
Definitely. Flow cytometry is a crucial tool used for diagnosing and monitoring acute myeloid leukemia. It is essential for identifying and characterizing the cancer cells by detecting specific proteins on their surface, which helps in confirming the diagnosis.
All right. And has treatment evolved recently for AML? Or is it still old school?
It has definitely evolved. We still use intensive induction chemotherapy, but now we also have targeted therapies based on the genetic makeup of the leukemia. For example, if the leukemic cells have a FLT3 or IDH mutation, we can use specific inhibitors. This is followed by consolidation therapy, which can be more chemo or a stem cell transplant for eligible patients. Immunotherapy and CAR T cells are also being actively researched, and we will see where that takes us.
That's crazy. And for prognosis, we can confidently say that genetics are king.
Exactly. Favorable features include being younger, a lower WBC, and cytogenetics like translation 821 and translation 1517. But unfavorable features include the opposite: older age, high WBC, and past history of MDS, and genetics like deletions in chromosome 5 or 7.
That's a lot to take in. All right, so you've mentioned a specific translocation, 1517. So we're talking specific leukemias, which brings us to our second case. A 20-year-old woman presenting to the clinic with fever and easy bruising for the past 3 weeks. Those are not just bruises, my guy. She's in full-blown disseminated intravascular coagulation, or DIC for short. Her bone marrow is packed with abnormal promyelocytes. This sounds like a specific nightmare we've learned about, right?
It is, to be honest. This is a hematologic emergency. Acute promyelocytic leukemia, or APL for short, is a subtype of AML, but it behaves so uniquely we have to approach it differently.
I love what you're saying, but why would you say so?
The two main things are its genetics and its complication. Genetically, it's defined by that specific swap between chromosomes 15 and 17. This creates a fused PML RAR alpha gene that blocks the cells from maturing past the promyelocyte stage.
Ooh, and that directly leads to bleeding?
Yes, exactly. These promyelocytes are packed with granules full of procoagulant material. When the cell breaks down, they dump the substance into the bloodstream, triggering that catastrophic DIC you mentioned earlier, causing both widespread clotting and bleeding simultaneously. It's life threatening and can lead to organ failure.
But there's a famous, almost clever treatment for this, no?
Yes, and it is the perfect example of how targeted therapy works. Because the genetic block involves the retinoic acid receptor, we can use a drug called all trans retinoic acid, ATRA. ATRA forces the leukemic promyelocytes to mature, basically telling them to grow up and die on schedule. Combining ATRA with chemotherapy has turned this from one of the most fatal leukemias into one of the most curable.
Let's do a quick check on that. What genetic abnormality is the hallmark of APL? A. Philadelphia chromosome 922. B. Reciprocal translocation 1517. C. Deletion of chromosome 5. Or D. Translocation of 1221.
That would be B, the 1517 translocation, as it's the defining feature.
All right, a quick recap to our amazing listeners. So, ALL is mostly seen in kids. AML is mainly seen in adults, and you should right away think our rods. APL is an emergency. Think DIC and treat with ATRA. This is a clean, simple, and memorable way to remember it. Kenan, let's hop back to the defective factory analogy we used earlier for our next interesting case. A 70-year-old man presents with fatigue that is increasing with time and seems to catch every single cold out there. He also notices he bruises very easily. His blood count reveals that he's anemic, has low white blood cells, and low platelets. His bone marrow biopsy reports that it's hypercellular with quote-unquote dysplastic changes in all 3 cell lines, but the blast count is under 20%. This doesn't sound like an explosive leukemia, but something is seriously very wrong.
Precisely, you've described the hallmark of Myelodysplastic Syndromes, MDS, perfectly. This was the quantity over quality issue I was talking about earlier. The marrow is busy, but it's producing junk. The formal definition is a group of stem cell diseases where the bone marrow produces dysplastic, ineffective blood cells, leading to low blood counts or cytopenias, with a risk of transformation into AML.
Oh, okay. So who usually develops this sort of dysfunctional, exhausted bone marrow?
It primarily affects older adults, commonly males, usually between 30 to 80 years, with the median onset being men in their 70s.
Oh, wow. That's interesting. Can you tell us what causes the factory's quality control to break down?
The pathophysiology is rather complex. where it involves distorted stem cell function, immune dysregulation, and messed up apoptosis. Causes can be unknown, so we call it idiopathic, heritable, like in Fanconi's anemia, Schwann-Diamond syndrome, or Down syndrome, or it is acquired from vitamin B12 folate deficiency or previous chemo or radiation, benzene exposure, or even after a bone marrow transplant.
So for diagnosis, the bone marrow biopsy is key. What are we looking for under the microscope that screams MDS?
We look for weirdly shaped cells in all lines. This erythropoiesis, oddly shaped red blood cell precursors, sometimes with ring sideroblasts. This granulopoiesis, which are neutrophils with poorly segmented nuclei known as pseudo-Pelger-Hoyt or missing granules. This megakaryopoiesis, which are small abnormal megakaryocytes with single or multiple round nuclei. The blast count must be under 20%. If it's over, it's considered leukemia.
On point. And once diagnosed, we use the IPSS to actually predict survival and guide a pathway in patient's therapy.
Exactly. The IPSS stands for the International Prognostic Scoring System. It scores the myroblast percentage, cytogenetics, and the number of cytopenias. A low score of 0 means a median survival of 5.7 years. An intermediate score of 1 to 2 means 3.5 down to 1.2 years. A high score of more than 2.5 means a median survival of only 0.4 years, highlighting the need for a very aggressive treatment.
And of course, depending on the severity we treat, right?
Exactly. For low risk patients, it's supportive care involving transfusions and growth factors such as ESA or GCSF. For those with a 5q deletion, the drug lenalidomide is fantastic. For high risk patients, we use cytarabine based therapy or the only potential cure, a bone marrow transplant.
Kenan, thank you so much for that perfect summary. So again, MDS is a pre-leukemic state of inefficient production, not a blockage, carrying a variable but significant risk of transforming into AML. All right, Kenan, our final stretch. Are you ready?
Yalla, let's go.
Let's talk about the terrifying oncogenic emergencies. These are time-critical situations. Let's rapidly go through them. First, a patient with lung cancer presents with a swollen, puffy face, swelling in their arms, and difficulty breathing. What's happening?
That's superior vena cava syndrome. The tumor is compressing or causing a clot in the major vein that returns blood from the head and arms. It's an emergency, and management focuses on restoring flow and protecting the airway.
All right, next one. A patient with advanced lymphoma suddenly develops shortness of breath, low blood pressure, and the doctor hears muffled heart sounds.
That raises immediate concern for cardiac tamponade. There is fluid or a tumor which is compressing the heart, preventing it from completely filling, and this requires immediate drainage or surgery.
Another classic. A patient with known prostate cancer with horrible leg weakness. What are we thinking?
That's a red flag for malignant spinal cord compression. This is a neurological emergency. You need an urgent MRI of the entire spine and administer high-dose steroids to reduce the swelling.
Up next is a metabolic one. A patient with myeloma becomes confused, constipated, and has abdominal pain. Blood work shows high calcium. What are we thinking?
That's malignancy-associated hypercalcemia. The tumor secretes substances that leach calcium from the bones. We have to treat it aggressively with IV fluids and bisphosphonates.
Perfect. This next case is a patient that's newly diagnosed with AML, with a WBC of 150,000, and suddenly becomes confused and breathless.
This is a test for the listeners who've been paying attention. The high WBC count acts as a sludge leading to what? Leukostasis. The obstructions are seen in brain and lung vessels, hence, we need to do an emergent leukapheresis to physically remove them, plus medication to lower the count as soon as possible.
And lastly, an examiner's favorite case. A patient with Burkitt lymphoma starts chemo and a few days later has muscle weakness and stops urinating. Labs show high potassium, high phosphate, and low calcium.
That's tumor lysis syndrome, a metabolic catastrophe caused by the rapid death of tumor cells. It can cause acute kidney failure and fatal arrhythmias. We prevent it with hydration and allopurinol and treat it with rasburicase and sometimes dialysis.
FYI, rasburicase is a urate oxidase, converting uric acid to allantoin, a purine metabolite more soluble than uric acid so it does not accumulate in the kidneys. So, to recap, These 6 emergencies range from structural compression to metabolic crises to treatment complications. Recognizing them quickly is absolutely vital. And that brings us to the end of today's clinically and examly significant episode. Kenan, thank you very much for helping us break down these complex topics into such digestible segments, from the pathophysiology of leukemias and MDS to the critical recognition of oncogenic emergencies that no one wants to miss.
يعطيك العافية حب. It's been a pleasure. I hope this helps our listeners feel more confident about these challenging topics.
And of course, thank you to our listeners for joining us on this episode of PodBites. If you found this useful, please subscribe for more bite-sized medical insights. Take care and see you next time.